Have you ever looked at a radiograph of a beautifully obturated tooth and felt a bit of obturation envy? What are the tricks and tools and materials the experts use to reliably produce root fillings that are biologically optimal and look so good on X-ray films? This evening we're joined by one such endodontic expert, Adjunct Associate Professor Mehdi Rahimi. Welcome. Mehdi, welcome to Care Dental TV.
Absolute pleasure. Thank you for having me.
It's great to have you here. We're coming to you from traditional Cameragal land in northern Sydney. We pay our respects to elders past, present and emerging. As you know, Care Dental TV is interactive, so please send us your comments and questions as we go. If you're watching us on Facebook Live, this next information is for you. If you'd like to send a question, you'll need to stop viewing us on Facebook and instead open your browser and go to the URL on your screen so you can watch the live event there. That's important because we won't see your comments or questions on Facebook until after this live event has finished. By watching us, you're eligible to claim 1 hour of scientific CPD, and we'll let you know at the end of the event how to get your CPD certificate. Mehdi, we hear a range of opinions when it comes to obturation, everything from it's not important at all, right through to it's super important. In your mind, why does obturation deserve so much of our attention?
Yeah, look, the reality is when you read textbooks and when you might read papers, I think the reason why they say it's the least important is because as part of the pyramid of treatment, accessing teeth obviously and locating all the canals, being able to effectively disinfect the entire root canal system is more important than, I guess, the obturation part, but the obturation and the restoration on top is still very important, okay? And the reality is when we look at the first slide here, and as Professor Paul Abbott from Perth says, we obturate to show the dentist the white lines. In effect, we're then demonstrating the function of good chemomechanical disinfection, and we can also assess the case and go, all right, we can improve on it should we decide to retreat the case. So obturation as a whole is important because once you've disinfected the case, for it to heal short and long term, you actually need to seal the root canal system. You need to deny the root canal remaining bacteria any space for growth, and you need to make sure you seal so there's no reintroduction of bacteria into the root canal system.
Well, where would you say then a successful obturation really begins?
The successful obturation obviously begins all from the time you start to instrument, and if you can't get your instrument to length, for example, you can't get to the appropriate working length and what we call establishing patency, then you are unable to allow the irrigants and medicaments to take the be effective at being antibacterial. And we know that they need to get to length because most of the biofilm is situated in the apical third and even around the root. So you need to be able to unclog the tube, if you like. And of course, once you've done that, you need to prepare the root canal system to a shape that you're able to effectively obturate. So if you can't do that, then the cones or the materials that you're using won't be able to seal the entire root canal system. And the other things, the glide path is very important in endodontics. We need to, because most people are performing endodontic therapy through instrumentation with rotaries, we need to make sure that we've got a smooth glide path all the way to the working length or to the end of the root canal system. If we don't have a smooth glide path, it is possible that we're putting a rotating instrument into the root canal system and we increase the risk of fracture and procedural errors. And I've got just one more slide on the glide path just to indicate to you guys that what I do every day in my clinics is I try to minimize hand instruments, and that's why I will use a size 6 and a size 8. My size 6 is a K-file stainless steel, my size 8 is a headstrom, so I can break down calcifications or bypass any irregularities within the root canal system. Others might choose other files. There's other files on the market, but I've got used to using stainless steel. And then I move on to a glide path, a mechanized glide path system by the Traverse file system. And my favorite out of the traverse file system is actually the 1306, which would be a very efficient, strong file to get me to the appropriate length.
We mentioned before the concept of canal patency. Can you talk us through that?
So we talk about biofilm being situated in the apical third of the root canal system. There's ramifications and it's stuck, it's adherent to that area of the root canal system as well as the tip of the root. So if we don't have the right working length or we lose working length, we can compact the root canal system with bacteria in effect. Patency is when you put a small file through the minor foramen, if you like, or through the narrowest part of the root canal system, and it exits the root canal and comes back in. Sometimes students in clinics think that's a perforation. It's not. What you're trying to do is you're trying to unclog the entire tube, the root canal system, so that then your irrigants can effectively work, your medicaments can effectively get into the areas that you can't reach with your instruments. It does prove that when you have patency, the literature and outcome studies prove there's a higher success.
Well, how then does the metallurgy or the metallic properties of the instruments work in with outcomes?
Yeah, so I've just got a slide on, I suppose, the evolution of rotary instruments. Initially, when rotary instruments were produced on the market, they were more what we call the austenite phase. They're still flexible, but compared to a stainless steel file, they're a lot more flexible and they're a lot stronger. But what we found using the austenite phase files is, especially when you go above a certain size, the thickness of that file means that they have shape memory, so they like to revert to their original shape. So what happens is that you can create areas of the root canal system on the inner wall of the root canal, for example, where you haven't touched. So it becomes very difficult to obturate that. And often you have a floppy, obturation cone because you've just basically removed too much inner dentine and within the inner wall of the root canal system, and it's impossible to disinfect that area because you've left a lot of areas that you haven't touched. So there's a spectrum, and this slide's meant to show the spectrum where files can, similar to the Zenflex file, which is it's very unique, this file, that can be less heat treated. The introductory files into the root canals can be less heat treated because they have lesser diameter, and they become more heat treated, so you can bend them and they keep their shape, so they have more controlled memory when they become larger in size. So it's the only one at the moment on the market that I know of that can do that. And I think the principle is quite important because the thing is, when you read various advertising, you hear that this heat treated file has 300% more susceptible to fracture. Well, that's not strictly correct, because what happens to that file, it keeps the shape of the root canal system because it's heat treated, it's a lot softer, it can maintain the S curvatures and difficult areas, curvatures. But the problem is you can leave it in one spot and it will take ages for it to undergo cyclic fatigue, but it's not very good, it's not very resistant to torsional. So that means that the less heat treated the file is, the more austenite fade it is, it's more, not only it's more efficient, it's able to cut, it doesn't blunt as quickly, but you can lean on it a bit more. So what dentists don't realize is if they're used to older systems and they lean on the file, they push on the file, you can't do that with the heavily heat treated files. The super flexible ones are actually quite easy to fracture in the root canal system, and they blunt very easily. So what I found is I need to combine the two, and I know a lot of endodontists do. I need to combine the austenite phase or the less heat treated files with the more heat treated. As I do the root canal therapy, I start with the less heat treated, so it's more efficient at getting me to length. It's not going to just be what we call flimsy or just stops at one point and doesn't go any further. And then I combine it with the more heat treated, where it's able to then follow the curvature and it's less likely to cause an elbow or transportation of the root canal system or strip perf.
Well, can you maybe then talk us through in detail your approach to instrumentation?
So I think we've prepared a little instrumentation video which I'd like to share. So I'm going to be using the Traverse Orifice Shaper as well as the Traverse Glide Path files combined with the Zenflex rotary files from Kerr Endodontics. I'm going to be using the elements emotions, and the setting that I will have throughout the entire procedure is 500 RPM and 2 Newton centimeters torque. Now I understand that everybody would use slightly different RPM and torque, but the average RPM and torque for a heavily heat treated file is around 500 and 2 Newton centimeters, so that's what I like to use. So the first thing I'm going to do is I'm going to scout the canal, because obviously we always need a working length and we need to establish patency with a stainless steel size 6. It could be a C-Pilot file, it could be a Nightie hand file, but I prefer the stainless steel K file. And the main reason for that is because it's able to more efficiently dig to the apex, and it's a small file. It is highly unlikely to straighten any canal. And so I use the smallest file to watch wind my way. And what I'm aiming for is establishment of patency, because obviously I want to make sure I've unclogged the most apical part of the root canal system, therefore my irrigant and all my files are able to get to the correct working length. So obviously working length determination has been done, and I've previously measured it to 18 millimeters. So once I've established patency, I double check the working length, and the working length is measured at 18 millimeters. So then I can keep the entire prep to about 17.5 millimeters, which is 0.5 from the working length. So following working length determination, obviously I would always be using irrigation throughout the entire procedure. I need to make sure the canal is bathed in irrigant. Some people would use lubrication as well, such as RC Prep. However, RC Prep or other lubricants of that sort can block tubules that have wax. So therefore, I'm not going to use RC Prep. I often use EDTA throughout the working length determination and throughout the glide path, because obviously it's able to remove inorganic debris and create a nice smooth path to the apical zone. Every other file I use is going to have a curvature, like a gentle 45-degree curvature. And that's already been measured at the working length of 17.5. This is actually a Hedstrom stainless steel. I like it because it's able to break down any calcifications within the root canal system. Some may prefer K files. And what I'm doing as I come out is I brush each wall, so the 4 walls, just to make sure I've got a smooth initial path. And often I would stop at this point and move on to my orifice shaper. So really, I haven't even gone to a 10 unless I'm struggling. And the main reason for that is even a size 10 is able to straighten that fine anatomy. So pretty much the size 8 is my go-to file unless I'm struggling to get to length. There's some sort of a ledge or blockage within the canal, then I may use a size 10, and often that's a H, to more efficiently get me to my working length. So once I finish with the size 8, I move on to the Traverse Orifice Shaper, which is 25 at the tip and an 0.8 taper. So it's a very fine taper compared to older orifice shapers. It's also able to keep the root canal system centered, because obviously it's a very flexible file. Not only it's strong, but it's also flexible. So I set that at 13 and at about 500 RPM. As it's rotating, I enter the root canal system and I start to brush each wall. I'm always dancing within the canal. I don't leave the file in one spot, because even this can ledge or fracture. So I'm always dancing. Once again, I have plenty of lubrication. I always clean the flutes. So as you can see, the flutes are quite dirty. So I always clean the flutes. And I proceed on to further irrigation to make sure the root canal system is as clean as possible. So now I move on to my favorite file of the system, the glide path file, 13 at the tip and 0.6 taper. I find this file has advantages over some other older glide path files or others on the market. It's more efficient, it's not as flimsy as you try to create a glide path. It is very, very strong, if you like, and it's a good combination between it being heat treated and also an austenite file. And honestly, getting this to working length in most files is a real torture test for the files. So again, I let it sort of rotate, and then I enter it into the root canal. And it's a very strong yet flexible file. And as you can see, I'm dancing with the canal. Once I get to length, I pretty much stop, and I don't go back in. And I always clean the flutes, making sure every single time I come out, any debris is cleaned out from the file. So following this, we use the ZenFlex. And as you notice from the ZenFlex files, there's this purple hue, which increases as you go from the smaller diameter file, like a 2004, which is this file here, to the 4504. And the main reason for that is as the file gets larger, it's able to keep the confines of the shape of the root canal better, because the thicker the file, the more likely it's going to straighten the canal. So it's had more heat treatment, therefore it's even more flexible. So I'm going to use the 2004, which is actually quite an efficient file to get to the working length now. And once again, I'm always moving within the canal. And that's as easy as that. Then I move on to the next file, which is the ZenFlex 2504. As I said from the previous file, it's had this purple heat treatment. And so it's becoming more and more, if you like, martensitic phase. And that's why when you bend this file, it keeps a little bit of a control memory, as you can see. But it doesn't keep as much control memory as the larger apical diameter size files. So we go to about, once again, to the working length. And again, I don't do much with this file. Once it gets to length, I come out. So in between each file that I've used, I should remember to use some irrigation. Because obviously I want to make sure I don't clog the especially apical zone with debris. Then I move on to the 3004 file, and then I measure it to my working length. And often this is where I would stop most preparations, either 25 or 30 04 taper, because my irrigant delivery and agitation systems are able to clean out the root canal system as well. But for the purpose of this exercise, I'm going to go all the way to a 4504, which in some less often, in some canals like the palatal of an upper molar or a distal of a lower molar, I might go to. And as you can see, again, these files have even more controlled memory. They're even more heat treated, because the thicker the file, the more likely it's going to straighten the canal. Therefore, it's a quite clever way to be able to keep the confine or the curvature of the file as you go down. And that's it. So I've gone to a 3504. So over here we've got the 4004. So 4004, often I use in a distal of a lower molar, especially if it's a wider root canal system. I might use it in the palatal of an upper molar as well. That is done, and we obviously move on to the next file, which is the 4504 taper, 4504. And I always give it a bit of a bend, because if the canal is straight, it'll just become straight. But if the canal has any curvature, different types of curvature, some of them might have S curvatures, at least it's able to follow the anatomy better. And often I would obviously irrigate after every single file I use, but for the purpose of the exercise, I'll skip that. And then again. And then that's it. we finished the preparation of the block to a 4504.
Well, the prep's looking good, Eddie. Well done. So would you use that approach for every canal that you instrument?
The answer is obviously it's a very versatile system. So there's a lot of tapers and sizes, 04 taper, 06 taper, and the sizes are all the way up to about a 5004 or a 5006. But the answer is no. Endodontists are, I guess, we're like a tradesperson where we've got lots of equipment and lots of different files, and we assess the case, and a lot of the cases we get are difficult cases, so we would need an armamentarium more than just one system. So I'm still not a fan of one system or one file system or one single file doing everything. I think that if you want to do more complex endodontic therapy and you like your endo, you're an expert dentist, just like most endodontists, you'll need a whole range of file systems within your pack in case you might need to fork out an older file and go, all right, I can't get down, let me try to. Some of the files actually, the austenite phase that I got trained in Melbourne to use, they actually barge down canals that there's no way you'll get down. So your only option is you perform surgery or extraction or try to find a way down, even if you can't follow the actual confine of the root canal. You try your best to break through that part of the root canal system which is fully blocked. So the answer is no. It's not for every single case, but it is quite a versatile instrumentation protocol. So I think the instruments that we do have with the Zenflex and the Traverse together do give you almost 90% maybe of the cases that you can treat.
All right, well, thank you for your questions. We'll get to as many as we can. If you are watching us on Facebook Live, welcome. I hope you're enjoying the event. Remember, though, if you do want to submit a question, you'll need to submit that via the kerdental.tv website, because if you submit your questions on Facebook, we won't see them until after the event. Well, Mehdi, that's the instrumentation stage done now. What then would you say are the key important factors of obturation?
Yeah, so the first thing is you have to obturate. Like, you can't just leave the canal empty with medicament over time. So your only realistic option is to actually, following disruption of the biofilm and the antibacterial part, actually fill the root canal system so you can put the restoration on top. And the obturation does play a role because, as we know, with any endodontic therapy that you're doing, there's a chance you're going to leave some bacteria behind. There are parts of the root canal system that remain untouched even by irrigants. So the remaining bacteria should be entombed. So the principle of entombment, there's indirect evidence for it, but it kind of makes sense to me that once you come to seal the root canal system and your seal is done well with the least amount of voids, and you also are able to pick up some lateral canals, or within the tubule you've bonded to those tubules that are remaining in the root canal system, then you're obviously trying to block out the remaining bacteria from nutrition, from getting nutrients and oxygen, so they are less likely to replicate. The synergistic effect we talk about, where maybe there's been reintroduction of some bacteria into the root canal system and they're able to work together to form a biofilm. Also, the gutta-perca component should at least be bacteriostatic, and we know that gutta-perca is bacteriostatic, so that means the bacteria can't grow on it. People have tried to impregnate antibiotics like metronidazole on gutta-perca. The issue of antibiotic resistance came up, and what kind of bacteria do you select for? Sometimes you're actually selecting for anaerobes if you're putting antibiotics on gutta-perca. So they stopped impregnating gutta-perca, but at the end of the day, it's very important that it's bacteriostatic. And if, in effect, you're sealing from the apical zone, where there could be some moisture, all the way to the coronal zone, together with the coronal restoration or the coronal seal, you're able to seal the root canal system well, as long as it's well, performed, the whole procedure.
So are there published studies to kind of support ways to obturate well?
Yes, so essentially there are studies that are weaker studies, so we can't say there's no studies. The studies are leakage studies and bond strength studies for root filling material. So they're measured with those two studies. how well a root filling material performs. But as a whole, we know the highest level of evidence is outcome studies. And so when we look at the most recent outcome studies, and that top one there is basically the systematic review of papers from 2003, 2020, and they sieve out the best papers and they review them according to what's best available evidence, and we found that the well-compacted root filling resulted in significantly better outcome. Absence of coronal seal, obviously, worser outcome, and presence of a lesion at the time of obturation is a worser outcome. So yeah, there are lots of studies on proving that outcome is affected. One of the main prognostic factors and the indicators for success is a well-compacted root filling with no voids, and when it's, of course, to the appropriate length.
Well, obviously there's a wide range of obturation techniques and materials available, and as a general dentist I'm going to say that it can be a bit overwhelming. Is it fair to say that range is expansive and growing?
Yes, well, definitely, because obviously, as you can see from the slide, a lot of what we have, unfortunately and fortunately, is manufacturer driven, but it does confuse the dentist. What I would recommend is you go for gold standards and you ask a more experienced person, like an expert in the field, an endodontist, what they think of a product that came out just on the market. Why would you go for a gold standard? Because it's proven over time to work, and they've written papers and independent papers. So the way you assess the papers, if you ever decide to read a paper, is to see if it's dependent, manufacturer dependent, or independent. So at the end of the day, it's good to have so many products, but it does confuse the person who's going to purchase them. I recommend you get products that are from Australia or from the country you live in. So they are, I guess, TGA approved. You don't just pick up a product that's somewhere random around the world and you ship it in. And I also recommend that you look at the papers and you learn to analyze papers or ask people that know how to analyze the literature well, so you've got the best available knowledge and the most appropriate knowledge.
Well, when it comes to gutta perca versus resin or sealers of any kind, what's the guidance on the relative proportions?
The well-established, sort of mostly well-established, so there might be about 5% of endodontists at the moment that disagree with this, but most of us agree that what you've got to do is you've got to increase your core, because the gutta perca or the core is the most stable component, and you need to reduce the sealer. And the reasons why you reduce the sealer is because sealers can shrink or contract over a period of time. They can dissolve away. They can also under load break down. So sealers are better in thin in most situations. There are some sealers that can work a little bit in a thicker film, but at the end of the day, occlusal load, just like the post-cement interface breakdown, the same thing can happen to sealers. So the most stable component is the gutta perca.
And that's what you're talking about. The GP is what you're talking about when you say increase your core.
Yes.
This is not the restorative core above the
No.
This is the core of the GP core of the root canal filling.
Exactly. It's actually the root filling, the gutta perca.
Okay. So with so many sealers on the market, what's your go-to?
So my go-to, the gold standard, where many people, when they study any type of sealer, they compare it to the gold standard epoxy resin sealers. So nevertheless, despite the new advents in bioceramic sealers, I'm still an epoxy resin user. One of the issues with epoxy resin was discoloration of teeth with the old AH26 because it had silver halide. Now the AH Plus version doesn't have that, and even there have been products such as the silver-free AH26, which means that if you like the consistency of AH26 being a little bit more viscous and being able to coat the walls of the root canal system better, you're able to now go back to AH26 silver-free. I do like AH Plus because it also comes in most of the AH Pluses that have been on the market, you can actually have a syringe where you can inject the base and catalyst together, so it makes your job easier. And I also like it because it's very stable over time, so it doesn't expand or shrink too much. And most of the studies you look at, it's always the gold standard it's being compared to. It's not any worse. If it's equal to the others, it might be better, but it's not worse.
All right, and I understand AH Plus is not the only sealer you use.
Correct. That's right.
What else are you using?
Any case that's above a size 50, or it might have some sort of resorption or an apical perforation, if you like, then I'm reverting to MTA, mineral trioxide aggregate, and this is actually the original MTA, ProRoot MTA, if you like, or MTAs of that sort. So I use that as a single, what we call monoblock. So similar to maybe people that I can think of as NHS system. The English dentist will use a paste and just spin it in. Kind of the same concepts come back now, almost like Back to the Future, where we're using a material that's only one material within the apical zone of the root canal system. You want at least 3 or 4 millimeters of that material for it to be effective seal. But I use it because if you're above a certain size, it's very sometimes difficult to control within the confine of the root canal system the material you have, as well as there's a lot of moisture. So the larger the apical size, the more the moisture is. So I like to compact the material. That's proven over time with many studies. The most studied material is MTA still, and it's proven that if you use it, this normal periodontal ligament and cementum grows over the top of it. A lot of the studies have been on surgical, but then there are also studies on pulpotomies where normal dentine grows over the top of it. There's no tunnel defects like some other products, and there's less likelihood of having leakage through it. So there's a very good thick natural barrier. If you extrude with the material, the other advantage is that it's very biocompatible. You can even put it under your skin and it won't react. So it's a very biocompatible material.
Oh, good to know. Well, thank you again for your questions. We'll get to as many as we can in the time we have. We've had quite a few questions on methods of compacting or condensing filling materials inside root canals. Some of us were taught lateral condensation at uni. Is that still a suitable technique?
When I graduated from University of Melbourne as a postgrad, I also graduated with lateral condensation only, pretty much. So we didn't have any warm vertical, condensation systems like the Elements IC. If we did have it, it was probably outdated, or we couldn't find the cords for it. We couldn't charge it. The charge would go die. So the reality is that I got taught with lateral condensation. I still think it's a very good system to have, very good method. But some of the issues with lateral condensation that I might touch on is, in case your canal is not as round, which most canals are not, and your spread is very thin, it's going to end up going quite deep within the root canal. And sometimes your cone might be an O2 taper, like the old days. So if your spread is going deeper, as you could have imagined, and the root is quite weak, you can actually put a lot of pressure on the root, and inadvertently you can have fractures and cracks. And I know of one endodontist that heard a crack as they were lateral condensing, so that sent shivers down their spine. The other thing, I'm sure you guys know this whole hedgehog effect. So you've added all these accessories and it took you ages, and then you heat it out and you don't know which one was actually effective and stayed in, and whether you actually removed all of it upon melting it out.
And it still doesn't look very good on X-ray films.
Correct, and we know from literature that you can leave more voids behind, doesn't look as good. So I would probably shy away from lateral condensation. However, because of the matched tapers, you're able to probably add less accessories. It made it more efficient, if you like. The good thing about lateral condensation, which I think we need to not forget, is you're able to control your length. This is not a good case. It might be a prosthodontist who's doing endo on every tooth, just in case one of them might need endo after they do crowns. You've got to use rubber dam, obviously, but it's just showing that you're able to monitor how well you've compacted, and whether the gutta perca, if it slips through, you can then readjust and take the master cone out.
So does the geometry of the GP point have a bearing on effective obturation?
For sure. So because you've machined the root canal system, now the geometry of GP, some of them might be 04 taper, some of them might be variable taper, depending on what you've used, is actually fitting better to the confine of the root canal system, especially in that apical half. So the coronal half Probably not. You still need to sometimes add a lot of accessories, or this is why we inject gutta perca at the coronal part, or we do hybrid systems. But apically, I think the geometry is a fairly good fit. And more and more these days, as you saw with the Zenflex, I'm going to show the Zenflex video, they're actually computerized. They're actually perfect fit. They're not hand rolled anymore. So that's also a very important advantage to have with new technology.
We've had some questions about warm vertical compaction. So what can you tell us?
So I had to self-teach myself warm vertical and watch videos with, Steve Buchanan and Herbert Schilder, 1960s and 70s and 80s. So I didn't have anyone hold my hand and say, this is how you do it. But the traditional warm vertical condensation does have some issues. That's what was taught in the past. One of the issues is you're keeping your apical sizes quite small, and in some cases, in some retreatments, in some cases where they've already been treated before, the canal anatomy or confine is already quite large. You need to sort of not keep your the small sizes at the apical zone. And what you're also doing is you're opening the top of the root canal system, so in effect you're removing the pericervical dentine, the most important part of the root canal system, which is the cervical aspect of the root canal. We're trying to be conservative. You're trying to open it up so you can put pluggers of different sizes and thickness down the root. So you are able to, with advantages, fill irregular canals and obturate lateral canals, and it's got good flow. However, when you do traditional and you heat so far down, you've got to get your pluggers really far down the root system. So that's an issue. And so, I think I just want to show a few cases, if that's okay. Pete?
Yeah, go for it.
One of the cases is a case of Mark Johnson's, who used to work with me in Sydney, and he's still part of our team, Gentle Endodontics, and he's in Melbourne, a very good endodontist. Is a case where it really demonstrates the importance of using systems that actually you're able to inject GP, warm GP in. And so this is an irregular canal system. You can't tell when you do your working length. You really can't tell anything about this case because you're looking at it and everything looks normal. But I just want to allude to the obturation. If Mark hadn't used warm GP to inject over, say, the cold apical zone, there was internal resorption that was impossible to see because it was bottleneck. So from the top of the axis, you can't see a thing, even under microscope and illumination. You could see that effect where if he's injected, you're able to get a better root adaptation. The root filling adapts to the walls better. But if you were going to do lateral condensation, you pretty much will be adding lots of accessory, and it'll be very voidy. You won't get your accessories to that mid-root, I promise you. And then the other case that I like to allude to before we show the video clip is a case where, this patient had some silver points. A prosthodontist got into a tooth and a silver point flew out because they were doing an inlay. Maybe they didn't take the appropriate radiograph, with all due respect to that prosthodontist. But they thought, well, this flew out, I better get Medi to have a look. So since the patients was seen till the time I saw them, they ended up with a flare-up. What happened is I think the bacteria were living in harmony with the host, and as soon as you get in and you stir it up, actually that lower 6, which wasn't touched, maybe it was vibrated, or maybe there was some vibration there, it actually started to flare up. So just to show that they found 3 canals 20 years ago, but there was actually 5 canals. And this is where I'm trying to demonstrate where we have single cone, cold, sort of apical zone, and then we backfill. And if you notice that lower 7, cervically or mid-root, it's a very different shape and taper. And if you're doing lateral condensation with an 04 or even an 06 taper cone, it'll take you ages to fill, and you'll never be able to adapt to the wall as nicely. And then the final sort of case I show you is a true combined lesion where, we didn't know whether we can save this tooth. It looks pretty hideous, and it looks like it's a fracture and you've got to extract the tooth. But upon discussion with my colleague, Dr. Hassan Melati, who's a very good periodontist, we decided, it's possibly a dens invagination that you can't see, that's inside the tooth, and it's possible this is endodontic in origin, or a true combined where he had to do some debridement periodontally. So as you can see, we medicated, we obturated, and you can really see how effective this system is at picking up lateral canals, and those lateral canals are very good. The principle of entombment is very important in this situation.
So then, can you talk us through in detail your approach to obturation?
So I think we've prepared a video on that, and I'd like to share that with everybody now. One of the issues we used to have with the original gutta-percha points is that, for example, you might have a gutta-percha point that's 25 at the tip, but then because it's hand rolled and not injection molded or precision made, it could be a 21 or a 30 or somewhere around between those figures. So it wasn't accurate, and it causes a lot of issues with the operator trying to get it to length, and it wouldn't go to the preparation length. So therefore, one of the advantages of using a precision made or injection molded gutta-percha like this 3504 Zenflex gutta-percha, it matches the preparation accurately, and almost every time, once you want to put it to length, it goes to length. And the other thing, if you notice, is the amount of flare. So you can see how slim that is compared to the wider tapered older versions of making or preparing root canal systems. So you're able to go to slightly larger apical sizes, which still, even today, despite the irrigant agitation delivery systems and them giving us advantages of, for example, being able to finish to a 25, sometimes in some canals you need to go to a 35, or in retreatment cases you might need to go to 35 or larger. And what you want is a larger apical size, but you don't want a terribly larger taper. So I'm going to measure up the 3504 Zenflex gutta-percha, and then I pick up a small amount of sealer. In this case, it's an epoxy resin sealer. And so I use a very thin amount of sealer because sealer is the weak link. And I place the sealer in 2 increments into very, very thin amount. And I make sure I've got good tug back. And we can even test the tug back by pushing out and pushing hard. The other thing about this particular system, because I'm doing a hybrid warm vertical compaction, is if I push hard, it doesn't slip through. So I make sure I push hard, and I make sure the gutta-percha doesn't slip through the apical zone or the foramen. So here we've got the elements IC unit, we've got the down pack, and we've got the backfill. Advantages of the whole system is that traditionally, for example, the elements free, it's very difficult to place the units back into the charger. It'll have to clip in. This is a nice, easy place back in type of friendly thing where it charges. It also keeps it charged for a lot longer, so I like that about the system. It's got a very nice screen. The cartridge, one of the advantages of the cartridge is that it is very easy to take out and put back in. And the other advantage, which is the main advantage, it's very easy to bend and unbend because it's got a nice copper tip. The old-fashioned systems were stainless steel, so once you bend and unbend, they fracture very easily. So it's easy to maneuver from one access to one root canal to another in the same tooth even. So while this is already ready to go, what I'm going to do is I've already measured the measurement to be 13 mils, so I don't want to go any more than 13. And the main reason for that is I want to be about 5 millimeters or so away from my working length. So your heat out's going to be about 5 mils short. For the very slender preps, and this is one example here, like an 04 taper or even a slimmer calcified canal where I've really minimally prepared, I like an 04 element. So the first thing I do is I heat the top portion of the GP, like so, and that's a waste, I get rid of that part. And then I would plunge into the center of this gutta-percha. So I often keep it quite centered, and I plunge in.
So I let that cool, and then I heat against one wall for about 1 second, let it cool. Heat against the other wall for about 1 second, let it cool. Then the third time I heat for a few seconds, I sort of wiggle and pull out the top portion of the gutter perker. And so I just wipe all that waste away, and then I move on to the smallest plugger, or maybe this plugger, which is the next size. And I go ahead and just sort of compact the GP down so that it basically, as it's being compacted, fills any lateral ramifications, isthmuses. And of course, most canals are not round, they're oval, so it's able to fit better within the confines of the root canal system. And I often would go back and I would repeat this step one more time. So that's why, I haven't got quite to the point that I wanted to with the first one. I like to do this twice. So therefore I go back in, I heat that a little bit more, wait 1 second, let it cool, wait another second, let it cool, a few seconds, and I pull out a little bit more of the gutter perker. So once I do it twice, I'm around about the 13 millimeter point which I want to be. So I just make sure I compact it very flat. The other thing is to keep that portion there as flat as possible. So you want to make sure it's nice and flat. So one of the voids you end up getting is actually at the interface between the backfill and the cold GP. So occasionally I might do it a third time, but most often twice is enough because the apical portion to mid-root portion fits the root canal system really accurately. I always use a bit of sealer at this point because you want a thin amount of sealer, but you don't want no sealer. No sealer means you won't get any bonding to the root canal walls, obviously. And then I move on to the backfill system. So the first thing I do about the backfill system is I sort of get the shape of the needle part correct, so it's able to go quite freely into the root canal system because every tooth, every area in the mouth is different. The second thing I do is I bleed the first part of the gutter perker, and what you see is this nice stringy softened gutter perker, almost like injecting GIC, comes out of that. So I bleed the first part. I must have this right over the top of that flat gutter perker. And the good thing about this unit is it's quite fine. It's a 25 gauge at the tip, so it's quite fine. You can see the surroundings, especially if you've got magnification, which with endodontics you should have. And then I inject, and I let it inject me up. And I inject in increments of around about 1 to 2 millimeters. I go to the larger plugger, which is this plugger here, and I'm able to compact that softened gutter perker. Once again, nice tuck fit against the root canal confine, and it's able to fit into any isthmuses, lateral canals, because most of that isthmuses are in the coronal part of the root canal system. That is why I use this system. And occasionally I use more sealer, occasionally I don't need it, and I go ahead and again do another increment. Some people inject in one attempt all the way to the top, but I like to do it in several attempts because I'm able to add sealer in between and make sure it's compacted well. And towards the top of the root canal system, if necessary, I add a little bit more sealer, or I might place a base. Sometimes I seal the top of the root canal system with a base. But for the purpose of this exercise, I'll inject another small fragment of gutter perker, and I might use the larger Buchanan plugger, and I go ahead and sort of just pack the top of the root canal system, as you can see. Might use a base over the top of this final increment of GP. So I like to just have a look at the quality of the obturation, and what I'm seeing there is no voids and a well compacted root filling. and it's a nice smooth tapered root filling. I do see a little bit of sealer puff, and the main reason for that is because I kept my cone to the working length, and I should have been around the middle short of working length, or maybe gone to the next size up cone like a 4004. And you can also see it's nice and well condensed up the top of the root canal system as well, which is what the aim is, to have no void at any interface between cold GP and warm GP, and also right through all of those increments of GP that I added. There's no void, there's just sealer and GP, quite uniform.
Well, thanks for talking us through, Mehdi. That's really good to see an expert in action. Thank you for your questions. Remember, if you're watching us on Facebook Live and you want to submit a question, make sure you switch to the URL that's on your screen now, because if you submit a question on Facebook, we won't see it until after the live event. So let us know how you're going by switching to that URL. Quite a few questions. The first one, Mehdi, why don't you use a single cone technique to obturate?
Yeah, so I understand that because of conservative endodontics these days and conservative accesses, sometimes it's very difficult to get a gutter poker cone in the root canal system and be able to effectively condense it. So people would just use, let's say, a bioceramic sealer of some sort and just use a single cone. I'm not a fan of that because I know, again, the weak link, as we discussed, is the sealer. And doesn't matter what kind of sealer it is, there's enough literature to suggest that over time the sealer will break down. If we're relying on sealer with occlusion, with load, it can break down. Any strong cement and bond to the wall will break down, just like post, cement interface over time. So that's why I prefer, once again, to have more gutta perca within my root canal system, be able to entomb the bacteria better, be able to access those isthmuses and lateral canals and ramifications within the root canal system as effectively as possible, and reduce the sealer. That's why I can't see any, at the moment, reason why a lot of people are promoting single cone techniques. I'm obviously in the camp that disagrees with that concept.
Next question, why not just use a Bunsen flame? Like, why are you using a fancy instrument?
Yeah, so I mean, this instrument here, which is obviously very versatile, one of the advantages is that you're able to press the heat button and it heats straight away. And the other advantage is it goes up to about 400 degrees. So if you want to do more traditional obturation, you're able to heat to a higher degrees Celsius, which previously you couldn't do. Obviously you only use 2-3 seconds, maybe 4 seconds within the root canal. You don't want to leave it on for 10-15 because you'll cook the ligament. But it is advantageous also because if, for example, you're doing a core and there's a bit of bleeding, in the past people, can use laser and hemostatic agents, but they can also use electrosurge, so they can kind of act like an electrosurge as well. If you use a Bunsen and you have, say, whatever heat you've got, by the time you get to the tooth, it will not plunge in the root canal and be able to heat it's just probably enough heat for searing off for lateral condensation, and even then it can not be hot enough. So I think being able to activate this and take your finger off it when you use it, it's very appropriate for what we do. And I don't think Bunsen burners, apart from my classmate in undergrad catching fire, she had long, beautiful long hair. Because of the Bunsen burner, I'm just fully against Bunsen burners. I think a heat source like this, we call it the System B heat source, is excellent. It's a great technology.
Well, I'm hoping your classmate recovered okay. Next question, sealer puffs, are they desirable or are they a problem?
Yeah, so look, the reality matter is that, this discussion's depends on who you ask this question from. So there are people that are very much anti-sealer puff, and there are people like me that sometimes they call puff daddy, excuse that language. The reality is that I don't aim for sealer puffs. I'm very careful adjacent to vital structures such as the mental nerve, such as the inferior alveolar canal, like a lower 7. I always take a cone beam CT to make sure I know where I am if I'm treating one of those teeth. I try to err away from getting the sealer puff. But if you clean the root canal system well, if you agitate the irrigant, you're going to open up and unclog. And because you're doing this heat pack system technique to entomb and fill the lateral canals, you've got a bit of flow, and as a result you can get a little bit of a small amount of sealer puff. All the sealers, most of the sealers used these days are biocompatible, and of course they're sterile when used, so I can't see it be an issue, a small sealer puff. We talk about older studies. I think the older study had its own, they have their own flaws. So I'm not going to go into studies and bore people, but a small amount of sealer puff you can sometimes control, and it does not mean that it's a crime that's going to result in greater risk of failure.
What sealer would you use in the case of a periapical infection? Should we wait for obturation after cleaning and shaping in such cases?
So, yeah, that question is, I suppose, for me, quite easy to answer. However, again, people have different schools of thought, so it depends on how this person who's asking the question has actually been taught. So the reality is you've got a periapical infection, but you know that 95% of the reason is within the root canal system. If you're able to effectively clean the root canal system and you're able to, there's no reason, you can't see a reason as to, all right, there might be a crack or there might be a reason why it might not heal. If you can't see a reason and it's quite a simple root canal system, then obviously you're able to agitate irrigants. Irrigants are such as sodium hypochlorite with higher concentrations, such as 4%, and you can even get 6%. They are very effective at removing the organic matter and being antibacterial. So in those sort of situations, in effect, you can finish the case if you're experienced in one visit, and I do that in one visit in cases where I'm performing intravenous sedation, where the patient might be traveling from a different state to have that treatment done, because maybe in that state they don't have it's not available for them. So in those cases, I just review after a core is placed, and I might review 3 to 6 months later. And in most cases, at 6 month point, 50% of the cases have healed. So as long as you've got a good seal up the top, that being the core, and the endodontic therapy is also done to a high standard, I see no reason why you should be using, for example, an antibacterial sealer. Most sealers have a certain degree of antibacterial properties anyway, but I'll probably err away from one type of sealer, that's a calcium hydroxide based sealer, because if you do overfill with that, it can be quite neurotoxic.
All right, well, a lot of questions on sealers. What are your thoughts on calcium silicate sealers?
Yeah, so I sort of have a slide on that which we didn't have a chance to discuss. So the reality is calcium silicate materials are new on the market relatively. And when you read some papers such as this paper, which is a comprehensive review but is not a systematic review, it's not a meta-analysis, which is a much higher levels of evidence, you see that they have a lower microleakage than most other sealers, if not all. They have a favorable antibacterial effect because there's a release of calcium hydroxide ions, and it's an excellent, very biocompatible. However, obviously with calcium silicates, there is a concern. The pre-mixed materials especially, there's a concern with them being bioactive. So this release of bioactivity can result in them not setting. So this whole thing about them not setting fully is an issue. I understand that people have done tests on them and they say they're set, but in some circumstances, there is literature or there's research to suggest they don't set properly within the root canal system. So my concern with this is that they don't have a long established track record such as MTA. People also use words such as MTA and label anything with MTA. You know, like MTA has proven to be the gold standard and has proven to have long-term effect. So the question is, how much MTA is in that material anyway? Some of them don't have much MTA and they're mixed with other products. So when I asked my uncle, Professor Torabinijad, he says, is this really science? When you completely change the properties, you pre-mix the material, so it's not freshly mixed, and you expect it to function the same way as the MTA studies. And the reality is also, if a material doesn't set properly and is releasing over time, it will dissolute away. We look at another aspect which is called bond strength testing, and we have a paper like it, such as this, that suggests that AH+ has a superior bond strength to the wall. So shear bond strength or push-out bond strength, they're the two main standard ways to measure the bond against the wall of the dentine. And that means that maybe calcium silicates are not bonding or not producing hydroxyapatite like you expect them to do in the most critical aspects of the root canal system. So again, in short, I would be very, very careful if I'm going to spend more money on getting calcium silicate and bioceramic sealers. I think, yes, they are manufacturer driven, but the literature is not supporting that at the moment. And I'd like to finish off with the paper that pretty much at the moment closes the chapter. It doesn't mean the chapter will open later and then future advances will happen. But this paper is compared MTA as a root filling material, as a retro filling material, which is probably the most critical aspect because you can measure how much cementum grows over the top of it, to calcium silicate based, so that's other bioceramics, and it compares it to Super EBA, which is an older product, and by far the number one best choice material when you meta-analyze and systematically review it, and it's a very good review. Professor Torbinijad puts his stamp on it. It proves that MTA is still number one choice, but the calcium silicate based are number two compared to other materials that we had on the market.
All right, well, a lot of questions to get through. Do you ever worry that the backfill needle tip could fracture during use?
Yeah, well, I mean, this is a really good question because for years I've had this issue where, because it's very difficult to get some of these into the difficult to reach areas of the mouth, like the upper sevens. We've contracted our accesses over time to preserve pericervical dentine. So the issue is this needle, some other competitor brands, as soon as you unbend, it fractures. But with this copper coating, it is so versatile, you can pretty much bend it in all directions many, many times and get into really difficult to reach areas, and it just will not fracture. It is very fine as well, so you're able to see where you're injecting. So I think this is a great advancement, and I think I caution people that may look at a different product and not see this, because that really bothers me. The cartridge is ready to use, it's heated, and I come to bend it into a different canal and it fractures. That sets me back by 2-3 minutes, and time is money.
Speaking of GP heating, do you have to wait very long for the GP to be ready to use?
So the reality is this system has a better battery life, and as with every technology, actually the technology of this sliding in is from the mobile world technology. So it slides in easier, it keeps its charge for about 27 or so canals, you're able to fill more teeth with it, and it actually heats up quicker. The cartridge is a lot quicker on this, and it keeps this charged longer as well. So I think all of these will probably improve with future generations as well, but I'm very happy because of that as well. I can see the difference when I use the older, for example, Elements Free version to the new Elements IC. I prefer this, but we fight over it in our practice.
Now, are the units available separately, or do they always come in a pair?
That's a good question as well. So you can get them separately. So if anyone wants to just have the heat out source, the System B heat source, they can. If they want to just have the injectable part, they can as well.
All right. When you're irrigating during the instrumentation phase, which needle tip are you using?
So I generally would use a very fine 27 gauge needle, and it's a side venting needle. And to avoid hypochlorite injury, I'm always, I don't want to wedge it in. I don't want to go too apical. I like to stay in the coronal half of the root canal, and I don't forcefully inject. So that's the key. If you inject under force, you're more likely to have a hypochlorite injury.
All right. How many dressings and how long would you wait in between appointments for obturation of an abscessed tooth?
Yeah, so good question. So as a general rule, we like to medicate the root canal system. We know the medication of choice with many dentists and proven to be the most antibacterial. Even if they mix it with other products, it's still the calcium hydroxide. It's the medication of choice. So if I ever medicate the root canal system with calcium hydroxide, I use Navi tips to make sure the calcium hydroxide's right through the entire root canal system. I obviously inject slowly and don't wedge it in. I stay 2-3 millimeters away from the apical zone, especially if the apical zone is open. I try not to place and pack the cavit right down so it squirts through. And typically 1 month is the maximum efficacy of calcium hydroxide. So after that, it's like a space filler. But I prefer 3 months, maybe even up to 6 months, as long as I've temporized with a double seal and I've actually braced the tooth wherever I can with a molar band, and I've indicated to the patient that they've got to clean around the band well, and my bands usually fit quite tuck fit and snug fit, so there's less likely there's overhangs and areas where it could cause a periodontal issue. So I like to wait 3 to 6 months, because at about 3 months you'll definitely see healing. At 6 months, 50% of cases completely heal.
Next one, what are your thoughts on activation of irrigants?
Well, obviously, I think the word agitation is better, as Paul Abbott always corrects me. I think agitating the irrigant is very, very, very important. And this is why we're able to prepare root canals to a smaller size than we previously did, diameter-wise. An initial root canal treatment of a calcified canal, MB2 canal, I go to a 20 or 25 these days. I don't need to go to what I used to get taught about with a 30, 35, 40 prep. And the main reason for that is because you can agitate. And the agitators today, some of them are so good, they connect to hand pieces, and they give you a really good acoustic streaming effect. And I feel that that has been one of the best, new and upcoming and future. I think they're all just improving on agitation techniques. I still don't think you need to buy what we call the Gentle Wave, which is an $80,000 machine, which agitates the root canal. So I think that's a bit overboard. And even lasers, I think in future, probably as they get less and less costly, people might have their uptake might be better. But I think just a simple agitator, definitely agitate. Very, very least, at least put an ultrasonic on a file and ultrasonicate that in the root canal. And always remember to keep the canal moist right to the very end, because even when you've got your master gutta-perca cone in there, when you're doing your your master GP film, before you obturate and dry the canal, keep it moist, because that passive manual dynamic agitation is still advantage. I think it's a form of activation / agitation.
If you are using an ultrasonic against a root canal file, what kind of file would you suggest? And is that to working length or just short?
Just short, probably about 1 mil short of working length, and you probably want to use a K file stainless steel.
And which size?
Smaller sizes, depending on the size of your root canal system. If you're going to use a larger one, then you probably want a night eye, so it follows the curvature.
All right, well, unfortunately, that's all the time we have for this evening. So, Mehdi, thanks again for being on Kerr Dental TV and talking us through the elements of a perfect obturation.
Thank you for having me.
And thank you for watching. To claim your CPD certificate, you'll need to fill out the form at the bottom of the viewing page. You'll also find a link there to some current promotions being offered by Kerr. Thanks again, and we'll see you next time on Kerr Dental TV.